go ahead and then I'll mute you when you're done. Should be good.
Hello?
Hi.
Hi, Carter. How are you doing?
Good. How are you today?
I'm great. Thank you for talking to us. So, welcome, everyone. This is our second IPHO meeting, and today we have Carter, who's a fellow at the Pharmacy Quality Alliance, and he's going to talk to us about his fellowship and tell us a little bit more about it. So, if you're good with it, Carter, you can just take it away from here.
Yeah, well, thank you very much. I'm very happy to talk to everybody today. And, we just had our fellowship application released online yesterday. So it's a pertinent time. We're getting into application season. So I'm very excited that I can tell you a little more about the Pharmacy Quality Alliance, answer any questions, and then let you guys know about some of the other student offerings that we have here. So to start out with, let's just make sure, sorry. Trying to advance the slide. Yes, so this is me. I am the PQA's Executive Fellow this year. It's a one-year-long fellowship, so I started in July, so it was July 1st of this year, and I'll go on until July 1st next year. I just graduated from Drake University in Des Moines, Iowa with my PharmD, and this is kind of my first post-grad opportunity. So enough about me, let's talk more about PQA. So when I say healthcare quality, what are some things that you guys think? Can you shout them out? Any thoughts? Maybe you're on mute here, but when we think about healthcare quality, we think about the stakeholders in quality. So on the left there, you see who defines quality, providers, patients, the payers, government. Those are all different stakeholders that maybe have their own definitions of quality. On the right, there's this very complicated map that was basically an outline of what your new healthcare system will look like under the Affordable Care Act. It's got like the IRS, the secretaries in the middle. And I always like to point out that patients are kind of in this bottom right-hand corner. So when we talk about patient-centered healthcare, maybe this isn't it, but we can think about ways maybe to move patients more towards the center. So as part of the Affordable Care Act, there was the National Quality Strategy that was created. And basically, it was a way for the Health and Human Services to establish a national strategy to improve the delivery of healthcare services, patient health outcomes, and population health. And those three things are really related to the triple aim and the 6 priorities in the National Quality Strategy. So the triple aim is better care, healthy people and healthy communities, and also affordable care. And whether you know it or not, we are actually doing all of these things all of the time. So some recent legislation that has come through about drug pricing relates back to this last bullet point here, making quality care affordable, individuals, families, employers, et cetera, et cetera. When we think about working with communities to promote wide use of best practices, we think about social determinants of health, and that's a big topic right now, finding ways to pay for that, finding ways to make sure we can address those social determinants of health. And there are other examples too of all these 6, but we think about these when we think about where our healthcare system is going today. So with that as well, we understand that in order to create those value-based outcomes, we have to move away from volume-based fee-for-service. So this slide illustrates an analogy of, the door is closing on volume and opening on value. The door is closing on fee-for-service and it's opening on the outcomes. And in order to go through that value-based outcomes door, we have the value equation. So this is one of a few fractions we're going to be talking about today. But this equation relates to what value. And people actually use this equation all the time, and you just don't think about it. So when you think about, when you go to buy a hamburger, you know what type of value you're getting by the quality of that hamburger over the cost. So if you wouldn't pay steakhouse, very nice, expensive prices for a McDonald's quality hamburger, that would just be an unfair value there. But at the same time, it'd be a great value if you had an awesome burger at a very low cost. And in healthcare, we think about this too. So in order to get the best value in healthcare, so whether that's making sure the patients get the best outcomes and everything, we look at, okay, what kind of quality care we're getting, and then what does that cost? Cost is easy to measure, dollars and cents, but quality is a little bit trickier. So that's where some of the other fractions we'll be talking about today come into this. So what is a quality metric? So a healthcare performance measure or a quality metric allows us to quantify the quality or cost of care provided to patients and their families. They allow us to gauge the quality of care in order to improve that care and outcomes. Like they say, if you can't measure it, you can't improve it. So we need to make sure, in order to find the best quality of care, that we can actually measure it. And how we do that is through a measure. So PQA specializes in pharmacy Part D measures, but there's lots of other healthcare quality measures out there. So in a measure, you have your numerator over your denominator minus exclusions. So your numerator is going to be people who actually receive that care, receive that outcome, where your denominator is everybody who is eligible to receive that action minus those who are not eligible. I know we're talking fractions here, so we're having to think back towards elementary school math. So a nice analogy that I like to use for this is a bag of M&Ms. So for me, a quality bag of M&Ms has a lot of blue M&Ms because I love blue M&Ms. So my denominator in this situation is going to be the entire bag of M&Ms. So that's every single M&M in the bag. That's all the different colors. And my numerator is going to be just the blue M&Ms. Also in this situation, I like to say my exclusions are the M&Ms that don't have an M, because we need to know that these are actually M&Ms. Could be a Skittle, could be a rock, you don't know. So that's why we need to make sure we take out those exclusions. So in this situation, in order to maximize this quality bag of M&Ms, I would have a large number of blue M&Ms, a low number of everything else. We can think about this in healthcare. We also think about potentially patients who are prescribed a statin. So in this situation, your numerator is everybody who's prescribed a statin medication. Your denominator is everybody who's eligible minus your exclusions. So that would be your pregnant patients, people who have intolerance to statins, things like that. So this is just another example. This one's actually using a PQA measure, which is comprehensive or CMR completion rate within Medicare. So your denominator is your entire number of patients in the plan that qualify for a CMR. So that's everybody on these Part D plans that can have a MTM CMR completion. And your numerator is the number of patients in that plan that qualify for the MTM that actually receive the CMR. So just another example of how they're used. Also, when we talk about measures in healthcare, there are three different measures, types of measures, really. We have structure-based measures, and those are characteristics of individual healthcare organizations. So in this analogy, we just say, that's the access to electronic medical records. So does your health plan or does your health system use electronic medical records? This is a yes or no question. It's a structure. Process-based measures are the delivery of a specific clinical service. So this is the percentage of individuals who receive a specific medications after a heart attack. So you have your denominator, which is all of the patients that came into your hospital who had a heart attack. And then your numerator is how many of them left with the correct anticoagulation. And this is more of a percentage. It's a process. You need to have those systems in place in order for these patients who come into your hospital to leave with the correct medications. So what is your percentage of patients that actually have that occur? And outcome-based measures, those are the ultimate goal of healthcare. A lot of times when people talk about measures of quality in healthcare, they're talking about outcome measures. So a common one that almost everybody has heard of is the 30-day readmission rate. So what is your ER readmission rate after a heart attack? Most of the time, people and plans don't really care how you get to these outcome measures. And what I mean by that is they don't care if you made sure everybody had the right medications, or you make sure that maybe somebody who's food insecure goes home with some sort of gift card so they can buy food for their family, or maybe a gas card. Maybe you get them rides to their health appointments. All of these things factor into readmission rate, but they aren't immediately apparent and immediately able to judge. It'd be hard to judge, okay, what percentage of patients actually get rides, or what percentage of your patients have to walk, or something like that. Whereas we're really looking at, okay, we just want to make sure they don't come back to the hospital. The fourth level that we sometimes think about is the patient experience. This is somewhat harder to measure because it provides the feedback on the patient's experience. So was the patient able to understand what their doctor was saying? Does the patient understand their medications? A lot of people are looking towards this in order to find new ways to measure their quality of healthcare. And more with our patient-centered care, we want to make sure that patients are getting the correct experience, but it's sometimes the fourth measure just because it's a little harder to measure and it's something we're still exploring. When we think about that too, we can also think about in terms of Yelp. So probably all of you have heard of Yelp before, where you go and see, okay, what are the rating of a certain restaurant? We can also think about that with health plans. So when you look at a restaurant, you think about with those star ratings that you have on the health plan or for the restaurant, lots of different things went into that. What was the food like? What was the service like? What was the atmosphere? Those are all things that contribute into that star plan rating. However, we also understand lots of people have other reasons for picking restaurants. Was it close to home? Was it the type of food they wanted? So in this analogy, the Yelp page is the health plan, and all of the different measures that you're using to judge that health plan, or in this case, the restaurant, would be things such as, what are your readmission rates? What are the other metrics that factor into that star rating? And we think about that in the CMS star rating plan. So in on planfinder.gov, which is a website that patients can use to find different health plans, there are star ratings. And these star ratings have lots of different ways that factor in, or lots of different things that factor into them. So whether they're different quality metrics, basically. And in that, you have 5, 4, 3, 2, and 1 star plans. So patients can look and see, oh, does this plan, it basically simplifies the quality metrics that this plan has. And these star ratings aren't just nice for patients to look at, they're also high risk for these plans and high stakes because 5-star plans get more money. So a 5-star plan gets a 5% bonus and higher rebate amounts, which could mean billions of dollars for that health plan. 4-star plans still get that bonus, and 3 stars and new plans get a smaller bonus. There's also enrollment implications. So 5-star plans get open enrollment all the time. So this is, if we think about a restaurant, is this restaurant open 24 hours a day, or is it only open 1 hour a day? You're gonna get a lot more business if you're open 24 hours a day than if you're only open for 1 hour, one day. Lower performing plans also get a scarlet letter from CMS. And all of the enrollees also get this scarlet letter. So they know, hey, I'm on an underperforming plan. I may want to think about switching next time I come around. They also get a low performer icon on planfinder.gov to really let everyone know, hey, a low star plan, this is a low star plan, think about a different one. However, we realize that patients also pick these different plans because of other reasons. Just like with Yelp, where you may pick, oh, what type of food was I feeling? With these plans, you may also pick it because, hey, all of my medications are covered. Maybe my doctor's in network. Maybe it's a brand name that I know. So we understand that star ratings aren't the end all be all, but they're a way for patients to really judge what type of plan they're in. And we like to say that medication use measures are PQA's sweet spot. So that's why this slide is a bunch of candy, is because these medication use measures in these star rating plans are where PQA fits in. So does anybody have any questions before I get more into what PQA actually is? I don't know if you can be unmuted or what, but I just want to make sure we all understand healthcare quality before I jump into more about PQA.
Anybody have any questions? All right, Cotter, we don't have any on this end.
Okay, sounds good. I'll continue on. So the Pharmacy Quality Alliance, we were started back in 2006 as a public-private partnership. This was around the time that Medicare Part D was implemented. And at that time, that's when government basically became the largest purchaser of drugs in the nation. So with that, they wanted to make sure that these drugs were being used in a quality manner. From that, we've kind of transitioned into a nonprofit quality measure organization, but we've kept our core base of a multi-stakeholder membership that's transparent and uses consensus-based processes in order to create these plan-based medication use measures. So the Medicare Part D star rating measures, those are still our bread and butter. We still maintain those and we still try to find new uses for them and update them, but we've also transitioned into making measures for commercial plans and for other sorts of quality metrics. And we'll get into that a little more later about what type of measures we have. So we really have 4 cross-cutting roles now. We're a measure developer, like I said before, so we use this consensus-based process to draft, test, refine, and endorse measures. These measures, they usually come out of gaps in different sorts of high priority areas of healthcare, aligning with that national quality strategy we talked about before. We're a quality educator, so we have quality workshops, webinars, It's what we do right now with our student outreach programs. We have an APPE program and the Executive Fellowship in order to spread these sorts of ideas and make sure people know about healthcare quality. We're a researcher, so we have a whole research team that informs new measure development, and they also do research and demonstration projects on potential new measures. And we're a convener, so we have this multi-stakeholder membership, and we like to bring them together in roundtables, collaboration, task force, and our annual meeting in the spring, and our invite-only PQA Leadership Summit in November. So I've talked a lot about our multi-stakeholder membership. It's something we're really proud of, just because we have a lot of different stakeholders in healthcare that help us create these measures. So if you look on here, 23% of our members are university and academic institutions, so they help us with the researching side and the educating side. We have health technology and data solutions that help us implement the measures. We have health plans, and they're invested because they actually use our measures, and they're the ones who are being measured on it in those star ratings. We have community pharmacies. We also have different associations, so ASHP, APHA, NACDS, they are all still our members as well. And we also have life science organizations, which we usually think of as drug manufacturers, because they're involved with actually creating the medications, so they want to make sure that they're being used appropriately. So this is our measure development process. I'm not going to go through everything on this slide because there's a lot here, and that's a whole nother talk. But what I like to highlight on here is just all the different groups and task forces that our members get involved along the process of a measure, all the way from measure conceptualization, so just thinking of the measure, all the way to measure endorsement and measure use and maintenance. So even after the measure has been implemented and is out there in the market, we have these measure update panels that will come back and look at it to make sure it's being used appropriately. And all along the way here, our member organizations are involved. So here are our PQA performance measure domains. So we have adherence, safety, use, and medication therapy management. So if you look on here, some of these just seem pretty obvious because they are ingrained in clinical guidelines. So one I like to point out here is the treatment of chronic hepatitis C, completion of therapy. With these new medications that completely treat hepatitis C, we know that continuing on and persistent compliance will treat you with chronic hepatitis C. That's great. We need to measure that to make sure patients are compliant with their medications. Not only is this the best practice for health plans to make sure that they are actually, making sure their patients don't have hepatitis C anymore, but also it's a cost issue. Somebody who fails therapy may get readmitted to the hospital, and that's just going to cost more money for the health plan. So a lot of these have that kind of dual purpose as well. We also have a whole suite of them around opioid uses that we have kind of packaged in an opioid disuse order package that people use. So making sure that, hey, is somebody on high dose? Are they getting from multiple providers? Just because the opioid crisis is so prevalent nowadays. So we want to make sure that there's measures around that so these health plans are being held accountable to patients that may be on opioids. Here's kind of a pipeline of some that we're thinking about. So these are a lot of them in our research team right now. We're going through that different stages of process. We're looking into actually specialty pharmacy now, looking into different adherence measures around diabetes medications and immunization status as well. So we'll see how these go in the future. So another thing we need to kind of talk about real quickly is the Pharmacy Quality Solutions. Pharmacy Quality Solutions is another company that PQA, Pharmacy Quality Alliance, owns a 51% stake in. And they're basically created to help manage the EQIP platform. And this next slide here kind of has a brief description of what the EQIP platform is. And basically, it's a way for community pharmacies to look at the current quality measures that they're being held accountable to and to see where they can make interventions in order to move these quality measures up. Sometimes this is visible at the community pharmacist level, and other times it's more of a regional based thing just to make sure that these regional chains are performing to these measures appropriately. There's even a way on here you can click and it'll link with your patients in order to see which patients, hey, maybe aren't compliant with their statins and need to have, an intervention such like that. So it's just something that we have to mention just because, it's a very similar acronym. We do very similar things and we do support each other. So we always like to make sure students and other people are looking out for this in their community pharmacies, because over 95% of community pharmacies actually use this platform to track how they're being measured for these different quality metrics. So now on to the part that I know you've all been waiting for, and this is the student section of the PowerPoint, where we talk about our different student offerings and how all of you can get involved. So we do have an advanced pharmacy practice experience, or an APPE rotation. It's a 4 to 6 week program for P4 students. It involves an application, which is not currently posted on our website, but it will be soon. If you go on our website right now and go to the education tab, you can see our whole student programs listed. And from there, you can read more about it. And also, we will push out a message to all of our academic affairs people when that application is open. We have a summer research internship. So it's a kind of more longitudinal rotation, we like to say. And it's an 8 to 12 week program for P2 and P3 students to come in and learn more about PQA. Also involves an application and an interview, but this internship is very helpful for these students. We also have a graduate student internship. This is more for non-pharmacy students to gain field experience. So we've had some students come in that do a communication capstone or a business capstone at our location. Some of the unique extracurricular options that we have are the PQA CVS Health Foundation Scholars Program. This is a year-long program where students submit projects in June, and then they work with a mentor in order to help develop this project, usually around a PQA measure or a quality metric. They get scholarships to come to our leadership summit, and then they get to present a poster at our annual meeting in the spring to talk about this program and this project that they worked on. This year we have 9 scholars from schools from around the nation, and all working on various projects in healthcare quality. We also have the Healthcare Quality Innovation Challenge, or HQIC as we like to call it, which is a team-based student competition very much like Shark Tank, where students will be put in a given a problem. There's a list of prompts and problems, and they propose a tech-driven solution to solve this hot topic. If you guys are interested in doing this, the application is now open. All the prompts are on our website. So again, under that education tab, and then if you look under student programs, there should be all the HQuick prompts. And anybody can submit a application for this and give us their pitch. And then we give scholarships to the top 3 teams to come out to our annual meeting and then present it live in front of a panel of judges. These students get, all of them, if you're flown out in the top 3, do get a scholarship in order to help develop this project further. And the top team will also get a bunch of mentions as well. We have had some top teams go on and actually create different solutions and actually further this idea. So again, like I said, if you're interested and you are interested in these prompts, look on there. And if you get a team together with a tech-based solution, we'd love to hear what it is. Some post-grad opportunities, we have the Executive Fellowship, which I highly recommend because it is the position that I'm in now. It's a full-time postgraduate program for 1 year. I get to do a lot of different things. I get to work with our Academic Affairs Committee and get to manage that committee in order to let them know about what things we're doing and get their feedback on some different projects and get some help with that. So it's a great way to not only network with our Academic Affairs Committee members, but also get experience in managing a committee. Not only that, but I'm working on lots of other various projects, helping support our teams in the Leadership Summit creation, getting an education program off the ground. I'm working with our CEO in some of the governance discussions that we're having, and it's just a great way to really get involved in this side of things. I also get to network a lot with the other associations here. So all of the other fellows in the DC area, we get together and we like to introduce our students to each other so we can make those connections. And then eventually, whatever we decided to do next, you have a strong network base here in DC for whatever you'd like to do next. The Academic Affairs Committee, like I said before, is kind of a forum for this PQA member organization, falls under the Executive Fellowship in order for me to manage as well. So the APPE student, the APPE student applications are not open yet, but I thought they were when I put it on here. There's the link in order to learn more about our student programs. The deadline is still going to be December 1st for that APPE program. So once it's open, it'll be on there. We do phone interviews in January, and then we push those offers out February 15th or thereabouts, basically. So with that, what questions do you guys have for me?
Do we have any questions? for the summer internship, when can you start applying?
Um, I think it is also going to be sometime soon that it's going to be open. Unfortunately, that internship is managed by our research team and not my team. So I'll have to double check on that, and I can get back to you as far as a timeline of when that will actually be open. But usually we give those offers sometime in February or March. So I would assume soon it will be open with the deadline sometime in December.
All right, thank you. Carter, why don't you tell us a little bit about why you decided to apply for a fellowship at PQA?
Yeah, absolutely. So during my fourth year, I did a rotation at NCPA, or the National Community Pharmacists Association, out here in Alexandria, Virginia. And during my time, I was involved a lot with different meeting planning, and I got to help with an education program that they did, and it was really great. And I really liked seeing this side of pharmacy and this kind of non-patient care side of things. I always knew that when I got into pharmacy, I wanted to do something different. And I never thought it would be this different. I mean, I don't see patients every day. I haven't given a flu shot in a couple of years. So I didn't think it would be this different, but I get to help support clinicians do what they like to do. So instead of giving 1 to 2 flu, or, hundreds of flu shots, I get to help clinicians support give, thousands of flu shots every year. That's just kind of one example, but I get to really see this 10,000-foot view of pharmacy. And it's very different and very interesting to see what all these stakeholders we talked about before think about pharmacy. I talked to some academic people who are very passionate about educating their students, which I really find interesting. But I also get to talk to people that are pharmacists at health plans who really think about what these new gene therapies are going to do to the cost of healthcare. And so I also get to see the cutting edge of pharmacy, I think, as far as policy and health, pharmacoeconomics and cost control versus benefit. So I'm really glad that I looked into this in order to see this side of things. So I would encourage anybody who, maybe does like clinical care, maybe does like seeing patients and impacting patients' lives, but also really wants to do something different in pharmacy and gets to see this side of payment and this side of how do we actually make sure that our health system is more affordable than it is now, and making sure medications are used appropriately, more specifically with PQA. Look into this fellowship and really or any of the associations out here, really. They have a lot of great association fellowships out here and residencies that you can just get involved with at a higher level in pharmacy. So I know that's kind of a convoluted answer, but basically I wanted to do something different, and I get to impact a lot of different ways of pharmacy that I didn't think I would have.
Thank you. That was really insightful. Do we have any other questions? Dr. Herndon. Does the fellowship require a PGY1 beforehand?
It does not. So I graduated in May, and I moved out here May 28th and started July 1st. So they do require you to get licensed in a state. I picked the state of Virginia because it's very close to federal law, and I live here anyway, so might as well give them more money, right? So that's the only real requirement. I also am required to get a CPHQ, which is a Certified Professional in Healthcare Quality Certificate. PQA actually pays for that and helps support me through this process of getting qualified, but it does not require a formal PGY1 training.
All right. Any other questions? Okay, well, thank you so much for your time, Carter. Thank you for giving us the PowerPoint. I'll be sure to share that with everyone here today on our webpage. But yeah, thank you so much for speaking with us. We really enjoyed your PowerPoint and your presentation.
Well, thank you very much. I hope you guys learned something. I hope you guys have a great rest of your day.
Thank you. Bye.
Bye.
Alrighty, so that was definitely different.